Hello, my name is Annie Habicht. I'm one of the residents at St. Joe's Hospital and the University of Michigan, both in Ann Arbor. Today, on behalf of my co-investigators, I'd like to talk to you about our research. We investigated the impact of a new senior emergency department on recidivism, hospital length of stay, and rate of hospital admissions. We have no disclosures. Senior emergency department is a new phenomena in the U.S. We've increasingly built new senior emergency departments across the country. The Trinity Health System in the Midwest has about 11 senior emergency departments. This is in concert with a growing senior population that we encounter every day we go to work. The unique features of a senior emergency department is that you have to be over 65. There's certain physical features that are helpful for the geriatric populations, such as non-skid floors, railings on the walkways, better lighting, bigger clocks. There's also certain core issues we address that are pertinent to the geriatric populations, such as screening for depression, delirium, polypharmacy. We were hoping with this study that we would investigate that the new senior emergency department would be associated with decreased frequency of return visits, and also be associated with decreased hospital admissions and hospital length of stay. We did this research in a large community hospital at St. Joe's Hospital. It sees about 80,000 patients per year. This was a retrospective. Is it 85? Okay, 85,000 per year. It was a retrospective cohort study. The data we collected was from an administrative database at the Quality Institute at St. Joe's. The way we designed this study is we divided it in between a pre-senior and a post-senior cohort. The senior emergency department was opened in October of 2010. The way we divided it, the timing, was that we used 6 months before and 6 months after the senior emergency department was opened. And we did it in the same time of year, just 1 year apart, October to April to 2010, and then October 2010 to April 2011. We included patients that were over 65, and that had a triage level over 2. Reason being that our triage level 1 usually go to our main emergency department, to the trauma base, because they need to be acutely resuscitated. Patients who were excluded were those who didn't meet the age criteria, those who didn't meet the triage level, those who had an undocumented triage level, and those that were seen in the emergency department 12 months prior to the start of the cohort. Overall, we had in total 8,154 patients that met the inclusion criteria. When we used our exclusion criteria, we weeded it down, and in total we had 3,936 in the pre-senior and 3,742 in the post-senior group, so well-balanced in large groups. Our primary outcome was recidivism, and we defined this as the time to return to the emergency department in both 30 and 180 days. Our secondary outcomes was hospital length of stay and hospital admissions. We used a specially designed prognostic variable, which is a return risk indicator, to control for the likelihood to return. The proportion of patients who return within 30 days was calculated for each of the 66 DRG categories in the pre-senior group only. The DRGs were then ranked by quintiles of increasing risk for return, and the rankings were then applied to each patient in both cohorts. We then used a multivariate analysis, which was to minimize known confounders. We used this to all outcomes. So our possible confounders were sex, insurance status, age, triage level, the return risk indicator. We then also used a Cox proportional hazard model to evaluate difference in time to return before and after opening of the senior ED within 30 and 180 days. This is just to show the demographics of our pre-senior and senior cohorts. I won't go through it all, but I'd just like you to see how well balanced the two groups are in terms of their age, the percentage of females, the acuity levels, the different insurance types. These are our results. So we did not find a statistically significant difference for time to return in both 30 and 180 days. But we did find that the risk for admission was lower in the senior emergency department group. There was also no significant difference in the hospital length of stay. So our conclusion was that the new senior emergency department resulted in decreased rate of admissions, but we were not able to show with all our interventions that we do in the senior emergency department that there was any impact on recidivism or length of stay in the hospital. Thank you very much.
4.5 minutes, 4 minutes, 30 seconds. That's
okay.
Great. So what about, why